Fantastic. So I'm going to talk about optimizing radiation therapy for esophageal cancer. I have no conflicts of interest to disclose. And we're going to talk about how we currently treat esophageal cancer with radiation, the role of IMRT and proton therapy, and where we might move forward from here. So I think Dr. Lin already went over a lot of the basic material of how we arrived at our current standard of care, but this is one of the trials that established chemoradiation as the standard for esophageal cancer treatment. And of course, this is the trial that told us 50.4 gray is sufficient and is not our routine to go any higher than that. Neoadjuvant chemoradiation was looked at in a lot of different trials until the CROSS trial kind of firmly answered that question for us and established it as standard of care for more locally advanced tumors. A lot of the time when residents ask me how do we treat esophageal cancer, I sometimes will point them towards RTOG 1010 protocol. The protocol was actually asking a systemic therapy question looking at trastuzumab in HER2 positive patients, but it has very detailed radiation guidelines that delineate what is the gross tumor volume, the CTV, which usually includes about 4 centimeters of sup-inf margin and 1 to 1.5 cm of radial margin, plus an additional margin for PTV, and the dose, standard dose for neoadjuvant therapy is 50.4 gray. As Dr. Lin pointed out, the current pre-op dose, there's variation between the CROSS regimen, 41.4 gray, all the way up to the more RTOG standard of 50.4 gray. And that seems to be the standard dose that we give for pretty much every scenario, post-op, definitive. The NCCN guidelines do note that a higher dose may be appropriate for cervical esophageal cancers, which are usually squamous cell, especially when surgery is not planned. And this is not meant to go over each one of the trials in detail, other than to say that our colleagues in Asia, for example, who see a much higher volume of squamous cell, it is routine for them to treat upper thoracic squamous cell carcinomas to a much higher dose, usually 60 to 66 gray. And I think even though the NCCN guidelines say 50.4, I think in reality, many of us probably do treat squamous cell carcinomas of the upper thorax to a higher dose. There's also been a debate in on the question of involved field versus extended field radiation therapy. There's a lot of retrospective analysis as well as prospective studies trying to look at this, mostly out of Asia. And there are many studies that look something like this, where you're trying to look at an involved field radiation, which probably consists of the primary tumor, which is outlined by blue here, and then usually about 3 to 4 cm margin sup-inf and about 1 to 2 cm margin radial. This is being compared to, it's probably harder to see what they're defining as extensive field radiation, extended field radiation that goes from pretty much above the superclave all the way down to the GE junction. Usually what these studies find is, not surprisingly, the bigger the area we radiate, the more toxic it is. And there's not been a definitive benefit in terms of cancer control. And so the standard treatment is still, we want that 3 to 4 cm margin, but probably not above beyond that. When we're treating upper tumors, we do typically say electively include the superclave, and when we're treating distal tumors, we do typically say electively include the celiac nodes, even if not involved. These days in America, as Dr. Lin pointed out, we're seeing more and more of these distal GE junction adenocarcinomas, which are near the diaphragm, and so we do have to be cognizant of 4D simulation, especially as we move towards more and more conformal techniques with smaller margins. So this study, for example, is showing that it's probably really hard to see the colors on this, but they're outlining a distal esophageal tumor. There's a dark red outline here and a dark yellow outline kind of showing the sup-inf extent of the tumor during respiratory cycle. And these are a couple of studies out of MGH and MD Anderson showing that if you want to be fairly confident you're including the respiratory motion of the tumor, then your radial margin needs to be about 8 millimeters and your sup-inf margin needs to be about 1.8 centimeters. Similarly, in this study, your radial margin needs to be about 8 millimeters and your sup-inf extent needs to be 1.5, and you actually have more respiratory motion below the diaphragm. So for example, if you're trying to cover the celiac axis, than you do of the primary tumor, which is above the diaphragm. And so that's kind of how we currently treat esophageal cancer. We'll go quickly over the existing data on different modalities of radiation, starting from our more classic 3D conformal, which typically includes radiation beams going APPA, and then since you're trying to take the esophagus to a higher dose than the spinal cord can tolerate, you have to go off-cord obliques. And then moving on to IMRT, which typically, of course, uses more beams of radiation coming from more directions. You get a more conformal high-dose region, and the key is to be careful that you're not spraying too much low dose in the area. And then the technology of proton therapy, where you have radiation beams that go in with no exit dose, so you're able to achieve reasonable conformality on the primary tumor, high dose region, and less low dose bath compared to something like IMRT. So there's been a lot of planning studies that have been done on this topic, including, for example, this is comparing a 3D conformal plan versus 3 different kinds of IMRT beam arrangement, 4 fields, 7 fields, 9 fields for a distal esophageal tumor, with primarily the purpose of lowering the lung dose. And they were able to show that in their planning study of 10 patients, IMRT can typically reduce lung V10 by about 10%, V20 by about 5%, and mean lung dose by about 2.5%, without significantly raising the dose to the other organs, including spinal cord, heart, liver, or total body integral dose. With IMRT, you can choose what you're optimizing, and so if you can also choose not to optimize your lung dose, but instead to focus on decreasing the heart dose. So this is another planning study of comparing 3D conformal fields versus a 5-field IMRT plan, where they saw a reduction in average mean heart dose of about from 28 gray to about almost 23 gray. And again, without increasing dose of the other organs in the area. So you can certainly optimize so that you're decreasing both lung and heart dose, but we are choosing between the organs that we want to shoot our beams through. Another form of IMRT is VMAT, which uses more beams of radiation coming from a kind of an arc therapy. And so this is a study that looked at 3D conformal versus IMRT versus rapid arc flattened filter free beams. And what they're able to show is that with rapid arc, you can get similar target coverage and OAR sparing, meaning if you're careful about how you're planning the radiation, your low dose bath with rapid arc won't necessarily be higher than with IMRT. So your lung V5 won't necessarily go up if you're careful about how you plan. And they're showing that for the lung dose, in terms of different locations of the esophageal tumor, you don't get much benefit in terms of lung dose sparing of IMRT or rapid arc compared to 3D conformal in the upper thoracic, but in mid-thoracic and lower thoracic tumors, you do see a decrease in the IMRT and rapid arc technique compared to the dark blue 3D conformal line. So then what about proton therapy? This is a paper that came out back in 1998, theorizes, saying that for 3D conformal techniques, again, APPA beams and off-chord obliques, compared to proton beams, which you can use either APPA without needing an oblique beam, or a PA and a left posterior oblique, you can end up with isodose lines that are superior to 3D conformal, so that you end up with both less heart dose as well as less lung dose on the side. This has been looked at in comparison of proton therapy to IMRT as well. So this is a planning study looking at a couple beams of posterior beam radiation covering a distal esophageal tumor versus IMRT. And so you see a definite visual difference in terms of the low dose bath. And on this table here, you see that the lung V5, V10, V20 are all lower, mean lung dose is lower, heart dose, liver dose are lower as well. The only thing you have to watch out for is the left kidney dose, because if you have a beam coming in from the left posterior oblique, you have to make sure that you're not shooting completely through your left kidney. And so that's for treating distal esophageal tumors, but for thoracic tumors, you probably don't want to use a left posterior oblique to shoot through your left lung. And so a more common technique is just APPA. But again, because of kind of the Bragg-Peak physics of proton therapy, you don't need oblique beams in order to meet dose constraints of your cord while still covering the esophagus. And so you get to usually end up with much lower lung dose. And the heart dose for this particular beam arrangement is not any better with proton therapy than IMRT, since you're coming APPA. As proton technology advances, a lot of proton centers that are newer are being built with pencil beam scanning technology rather than passive scatter. And so with pencil beam scanning, it's actually possible to just use a single posterior beam of radiation, treat the esophagus to over 50 gray, and still keep the core to less than 45 gray. And so with this, you can imagine that compared to the APPA or 2 posterior beams approach, you're further lowering the heart and lung dose. So it's all well and good to show you pictures and say, hey, radiation dose is lower, do patients care, does it matter in terms of clinical outcome? This has been tried to look at as well, a lot mostly led by Dr. Lin's institution and by himself. So this is a study that looked at a propensity score comparison of 3D conformal treatment versus IMRT in a cohort of patients undergoing neoadjuvant chemoradiation prior to resection. And what this shows is that in terms of overall survival, The red curve is the IMRT group. The black curve is the 3D conformal group. Overall survival seems better with IMRT, and local recurrence also seems improved with IMRT. There seems to be no difference in terms of metastatic events or cancer-specific survival in this particular cohort. And they broke down the cause of death into 4 major causes. Most patients are dying from cancer. Some patients are also dying from pulmonary or cardiac complications, and then all other causes. And what they found was that when you look at 3D conformal versus IMRT, cardiac death is much lower with IMRT, as well as all other causes, but cancer-related death and pulmonary death appears to be the same between the two groups, possibly related to the dosimetric differences between the two modalities. Other institutions have tried to look at this as well. For example, the series out of Moffitt, they were not able to confirm the findings of an improvement in overall survival with IMRT, but they did see less weight loss with IMRT treatment, as well as less grade 3+ toxicity. And so a much larger analysis was done using the SEER database of IMRT versus 3D conformal treatment in patients that were greater than the age of 65. Vast majority of the over 2,500 patients were treated with 3D conformal rather than IMRT, although the study does point to an increased trend in the use of IMRT over the study period from almost 0 in 2002 to 30% in 2009. And they were able to confirm that the technology does not seem to make a difference in terms of cancer-specific survival, but there's less cardiac death with IMRT, as well as all-cause mortality. So what about proton therapy? What is the data for that? This is one of the earlier series that came out of MD Anderson in 2013 that looked at the overall rates of both GI and pulmonary complications, the 2 major classes of complications after esophagectomy. So this is within 30 days post-op after neoadjuvant chemoradiation, showing that compared to 3D conformal, both IMRT and proton beam therapy are better in terms of lower toxicity risk, although there seems to be no statistically significant difference between IMRT and proton therapy itself. They also try to look at, does it really matter in terms of modality, or is it just that each modality is associated with different risks, different doses to normal tissues? And so for pulmonary complication, for example, 3D conformal typically is associated with the highest mean lung dose, these red dots, whereas IMRT has lower mean lung dose and proton therapy probably has the lowest. And the differences in terms of toxicity can be accounted for by the differences in the normal tissue dose rather than the actual different modalities themselves. And so this is the latest data that was just published online 2 weeks ago that looked at a multi-institutional analysis of radiation modality use and post-op outcomes of neoadjuvant chemoradiation for esophagus cancer. It was over 500 patients from 3 different academic institutions, a modern cohort, and trying to account for the fact that this is not a randomized study, but what can we do to reduce the bias. And what they found was looking at 3D conformal treatment versus IMRT versus proton beam therapy, there seems to be a consistent decrease in terms of pulmonary complications post-op. There was a consistent decrease in terms of cardiac complications post-op, as well as wound healing complications seems to be much better in the proton therapy group than the other groups. There also seems to be a difference in terms of length of hospital stay. Of course, this is still a retrospective analysis and not a randomized trial, but that's underway as well. And so when you look at a multivariate analysis for factors that are most significantly influencing the development of complications, both pulmonary complications, cardiac complications, and wound complications, there's consistently a superiority of IMRT and proton beam therapy compared to 3D conformal. There is usually a trend towards an improvement of proton beam therapy versus IMRT, and if you lump 3D conformal and IMRT together in terms of photon therapy, there is an improvement of proton therapy, but usually when you're looking at proton therapy versus IMRT itself, the differences are not always statistically significant. And so I think moving towards the future, what can we look forward to in terms of radiation oncology treatment of esophagus cancer? I think probably it comes down to personalizing therapy so that we move beyond everyone who has esophageal cancer gets 50 gray, because we know it works for some patients and it's actually too much dose for some patients, since in the cross study you have path CR even with 41.4 gray. but we also know that local recurrence is still a problem. So for example, in 2012, this nomogram was already published looking at predicting response to chemoradiation, looking at factors such as pre-treatment and post-treatment PET-CT and EGD, trying to predict who's going to have a PAT-CR with an AUC of 0.7, which is good, but far from perfection. There are also more recent data, a lot of excitement looking at diffusion-weighted MRI, especially this series out of 20 patients, looking at MRI imaging pre-treatment, 8 to 13 fractions during treatment, and then pre-surgery, and finding that if you look at the change in the ADC map during, with a threshold of about 29%, meaning more change is better. So for a this is images from a PAT-CR patient with a change of 48% and a patient who had poor pathologic response to treatment with a change of -1%. If you set the threshold in this small cohort of 29%, you have sensitivity of 100%, specificity of 75%, with very high positive and negative predictive values predicting residual disease. And so hopefully we'll see more promising data with larger cohorts confirming this. There's also many, many studies trying to look at biomarkers predicting response to neoadjuvant radiation. This is just the summary table from a review, trying to look at whole genome gene expression analysis, picking out different gene combinations that have different predictive values for who's going to develop a PAT-CR, so that hopefully one day we can move into a trial somewhat similar to this one, where you start with therapy and then you actually assess response and then tailor your therapy according to it, so that one day maybe we can treat a patient and say, this gentleman only needs 40 gray and he's done. He'll develop pathologic response, complete response to his radiation, but this gentleman needs 60 gray, or perhaps we should just quit radiation and send them to full dose chemo entirely. So I think that brings me to the end of my section.